Assalamu alaikum wa rahmatullahi wa barakatuh. My last lecture about lung cancer or bronchogenic carcinoma, and we'll speak about the epidemiology, the size of the problem, etiological factors, genesis of the lung cancer, histological classification, how to investigate for lung cancer, clinical presentation and treatment, and how to detect early lung cancer. Epidemiology. Bronchogenic carcinoma or lung cancer, both terms used synonymously. Lung cancer from the airway and parenchyma, while bronchogenic carcinoma usually from the airway. The size of the problem. Almost worldwide in 2012, the lung cancer occurred in 1.8 million people and resulted in 1.6 million deaths. More than 85% of those affected they will die within the 5 years. Causes of death in men and the second or third in female. So it makes its most common cause of cancer-related death in men and the second most common in women after breast cancer. The most common age of the diagnosis is 70. In the United States, 5-year survival rate was 19.4%, while in Japan was 41%. The outcome and the average are worse in the developing country. In Gaza, we noticed in the last years almost the doubling of the number diagnosed with the lung cancer. As we mentioned, the age was 70, male more than female. Now the ratio 2 to 1. A decade ago was 10 to 1. It is the leading cancer death in men and the second leading cause also in female. So in the last years we noticed also increment in the number of lung and bronchogenic cancer among men and female. The incidence of lung and bronchogenic cancer almost 13%, and the same as in the female, 12% new cases. Tobacco smoking. The smoking is the most common cause, is the main contributor for lung cancer. Cigarette smoke contains at least 73 known carcinogens, including benzo and pyrene, radioactive isotope, a lot of carcinogen in the cigarette. While also in 85% of bronchogenic cancer occur in the smoker. Half of all regular smokers are eventually killed by their habit. It is dose dependent. Risk goes down after more than 5 years of cessation. Obstructive lung disease, patient with COPD, they have the worst spirometry and they have also the risk factor. Also passive smoker. Atmospheric pollution, occupational factor, asbestos, radioactive material, and pulmonary scarring. Passive smoking also is the inhalation of smoke by the others smoking. It is also the cause of lung cancer in non-smoker. Usually sometimes affect the female patient, and the most common form of cancer, adenocarcinoma. Risk of cancer after giving up, as we noticed, after 5 years the incidence of the risk of cancer goes down. Moderate and severe COPD is an independent risk factor for developing lung cancer. Also the financial loss in the developing country, almost the family income, 7% من family income they spend it in smoking, while 3% in health and 2% in sport. Genesis of the cancer. over a period of 3 to 4 years. Hyperplasia, which is the cell proliferation, lead to the metaplasia, with the transformation of one differentiated cell type to another differentiated cell type, then dysplasia, abnormal development of the cells, then carcinoma in situ, then invasive cancer. Radiation, smoking, occupational, oncogenic events كلياتها could affect the pluripotent cells, which can give rise to all of the type of the cell types that make for the body. Then we can result in small cell lung cancer or non-small cell lung cancer. How we can classify the lung cancer? We can also, based on the histopathological classification, non-small cell lung cancer account for more than 75%, adenocarcinoma, which is the highest incidence, 35%, then followed by squamous cell carcinoma, large cell carcinoma 10%, small cell lung cancer 20%, and the others 5%, like carcinoid pulmonary lymphoma, mucoepidermoid carcinoma, adenoid cystic carcinoma, and sarcoma. The mutation, all of mutation resulted from exposure to the carcinogenesis and result in activation of the oncogenes or inactivation of a tumor suppressor gene that resulted in cancer formation. The four main types of lung cancer: adenocarcinoma of the lung, زي ما احنا شايفين here. The high-powered photograph demonstrates a typical assigner pattern of glandular differentiation observed in adenocarcinoma. While here in the squamous cell, we can see the keratin here, which appear as waxy dark staining eosinophilic cytoplasm in patient with squamous cell carcinoma. Small cell lung cancer, high magnification photograph, typical cytological feature of small cell carcinoma of the lung. While here in large cell undifferentiated carcinoma, the large cell undifferentiated, the tumor cells have vesicular nuclei, prominent nuclei, and abundant eosinophilic cytoplasm. The clinical presentation of the lung cancer: usually there is no symptoms or specific sign or symptoms which may suggest lung cancer, but sometimes respiratory symptoms, the patient can be asymptomatic or symptomatic presentation, and these symptoms can be either like secondary to the local manifestation and intrathoracic spread في الcentral tumor, في peripheral tumor, في regional spread, or secondary to extrathoracic manifestation or paraneoplastic syndrome. Respiratory symptoms: coughing up blood, hemoptysis, wheeze, shortness of breath, where systemic symptoms like weight loss, weakness, fever, clubbing of the finger, and sometimes symptoms due to the cancer, metastasis, chest pain, wound pain, superior vena cava obstruction, difficulty in walking. ربع البيشنت they have no symptoms, as I mentioned. Discovered the pre-operative evaluation for other concern, نطلع nodule or mass. The symptoms, most of the patient they have تقريبا 3/4 العيانين بيكون secondary. If they have central tumor, squamous and small cell carcinoma, they have coughing حوالي من 45 إلى 75%, persistent cough not ameliorated with medication. Hemoptysis برضو عند 35% they have, but rarely the severe hemoptysis can be presented with lung cancer. Dyspnea, chest discomfort, wheeze, stridor. A peripheral tumor like adenocarcinoma or large cell carcinoma, usually asymptomatic, cough and hemoptysis. but less than central lesion. Bronchorrhea, it's in more than 10% of a bronchoalveolar carcinoma. Dyspnea, and also pain from pleura and peripheral chest wall involvement. Local spread في البانكوست tumor, pleural invasion can cause pleural effusion, sympathetic chains involvement, result in Horner syndrome, left recurrent laryngeal nerve, result in hoarseness, occlusion of the vena cava, superior vena cava, obstruction syndrome, esophageal compression, result in dysphagia, phrenic nerve, injury, result in hemidiaphragmatic paralysis, and sometimes mediastinal syndrome with obstruction. Extra thoracic manifestation. Most of these symptoms result from distant metastasis, supraclavicular or anterior cervical node also enlargement, bone pain, secondary to bone mets, liver mets, sometimes jaundice. The patient can be present with jaundice or right hypochondrial pain. Today we did the bronchoscope for a patient who just presented to the hospital with right hypochondrial pain and jaundice and found to have left hilar mass. Adrenal metastasis and may occur and most commonly seen in a patient with a small cell lung cancer. Intracranial metastasis occur in 10% of the patient at presentation. Paraneoplastic syndrome دايما بتكون في السمول سيل lung cancer more than non-small cell lung cancer. Syndrome of inappropriate antidiuretic hormone secretion or SIADA. Ectopic Cushing syndrome ECTH. Hypercalcemia, parathyroid hormone releasing, and the myasthenic syndrome, hypertrophic pulmonary osteoarthropathy, and hematological manifestation like anemia, DIC, or migratory thrombophlebitis. Staging of the lung cancer depend on the TNM score. T0, T carcinoma in situ, T1, T2, T3, T4, T0, there is no evidence of the primary tumor, T1 if the tumor is less than 3. can be also resulted in diagnosis. زي ما احنا شايفين هنا this is a case of left hilar mass, central lung mass, could be a squamous cell carcinoma or small cell lung cancer. This is all type of central bronchogenic, and here also there is metastasis in the same side. In this patient we have left upper loop collapse secondary to the endobronchial mass that lead to collapse and obstruction, which is Loftschild sign. And this patient, once you see the chest X-ray, you need to request CT scan and bronchoscopy the next day for diagnosis. And also here with cavitary lesion with air fluid level in patient with lung cancer. Here also there is a complete obstruction of the left main bronchus, result in collapse of the left lung. Sometimes also there is metastatic changes or lymphangitis carcinomatosis with multiple lymph node enlargement. Also one of the modality this picture that denoting maybe this patient is having lung cancer. CT scan also important. As we see here, there is solitary pulmonary nodule in the left lower loop. This is cavitary with thick wall cavity. Here, as we see also, there is enlargement of the mediastinal lymph node, and this is a patient with the Pancoast tumor. This is what is said a former of PET scan. If there is malignant lymph node or malignant enlargement of the tumor, it will decrease uptake of the glucose, so will give shining up in the CT in the PET scan. This is the way of CT guided biopsy. They can go directly for true cut biopsy from the affected side. So sometimes you can investigation also we can request for sputum cytology. It's simple non-invasive method. It can be used for patient with central lung cancer, lower lobe, large tumor. Sometimes diagnostic is up to 50%. If failed, we can also do bronchoscopy, bronchial wash, transbronchial biopsy, transbronchial needle aspiration, or sometimes for mediastinal lymph node we can do endobronchial ultrasound or EBUS. هو عبارة عن جهاز منظار عادي، لكن في آخره موجود برضو ultrasound probe لتحديد الميدياستاينال lymph node or central masses، وممكن ناخد منها fine needle aspiration and spot. Sometimes pleural fluid aspiration or pleural biopsy, mediastinoscopy by the thoracic surgeon or BATS video assisted thoracoscopy. All these tests should be done for the patient. وممكن نعملهم patient هذول pre-op assessment or by spirometer to assess if we are going to do lobectomy or segmentomy for lung cancer management. هنا زي ما احنا شايفين this is a large mass almost obstructing the main trachea, so it is very advanced fungating mass. How to differentiate? Lung cancer can simulate any chest condition. TB can be also one of the differential diagnoses. Pneumonia, sometimes non-resolving pneumonia, differential diagnosis is lung cancer. Abscess formation, pulmonary infarction, coin lesion اللي هي بتكون benign tumor, tuberculoma اللي هي بتكون very well rounded solitary pulmonary nodule, hydatid cyst, striated lobule or AV malformation. all other causes of a pleural effusion. How we can treatment of lung cancer depending on the stage. Very important staging of the lung cancer. So non-small cell lung cancer, stage 1 and stage 2 go for surgery. Stage 3A, we can offer the patient new adjuvant chemotherapy. Then we can, after shrinking of the size of the tumor, we can go directly for surgery. 2P and 4, stage 2P and 4 for chemotherapy, and stage 4 also we can refer the patient for palliative treatment. Small cell cancer, also we can, the limited stage of small cell lung cancer, radiation therapy plus chemo, and if it is extensive disease we offer the patient chemotherapy. وبعض الأحيان as a palliative treatment we refer the patient for radiation therapy. So the treatment of non-small cell lung cancer, stage 1 or 2, adequate pulmonary reserve يعني بنحددها عن طريق السبيروميتر، وبالتالي الفيف 1 لازم يكون اتليست أكتر من 1.5 لتر. Patient we can offer him for lobectomy or pneumonectomy, dissection of the lymph node, and only 12 to 15% of all patients with non-small cell lung cancer they have a chance of curable operation، لأنه early discovery في الحالات اللي زي هاي plays an important role. Stage 3A, of course we have to, for any patient diagnosed with lung cancer في حاجة اسمها multidisciplinary team بيكون فيها الأونكولوجيست، الراديوثيرابيست، الراديولوجيست، الهistopathologist، thoracic surgeon, and the pulmonologist. They make a team and decide which option is good for that patient. Radiotherapy, radical radiotherapy with a curative intent, 50 to 60 gray. For also palliative radiotherapy can be also one of the options. Chemotherapy for stage 4. But it does not improve the survival. Platinum-based combination or multi-modality therapy. Endobronchial treatment, interventional bronchoscopy. بعض الأحيان إذا كان في large tumor زي ما احنا شايفين هنا almost obstructing the trachea, the patient will suffocate or having a severe stridor. We can do laser, we can do electrocautery and organoplasma coagulation in order to open the trachea. بعد ما عملنا الأرجونوبلازما coagulation, it almost open the trachea. Photodynamic therapy and endobronchial radiotherapy، وهذه كلياتها من الendobronchial or can be, this treatment can be conducted by interventional bronchoscopist. For treatment small cell lung cancer, chemotherapy, radiotherapy or surgery. For limited disease, median survival without chemotherapy 3 months، لكن if with chemotherapy 14 months. طبعا the prognosis of small cell lung cancer is very bad in comparison to the patient with this non-small cell lung cancer. والميديان في النون سمول سيل لان كانسر في stage 0 or stage 1 almost 70% they have 5-year rate of survival, which is good prognosis rather than small cell lung cancer. Early lung cancer detection, we can do sputum cytology, automated sputum cytometry, X-ray, or low-dose CT scan. Sometimes low-dose CT scan also lung cancer, chest X-ray, sputum cytology, diagnosed at early stage, sometimes improve survival, no change in the mortality. CT screening for lung cancer. They recommend annual screening for lung cancer with low dose computer tomography in adult age من 55 ل 80 years with who have a 30 back year smoking history and currently smoke or have quit within the past 15 years. Not known yet if mortality is affected, but it has picked up a lung cancer at earlier stage. false positive and false negative طبعا هتكون موجودة و screening follow up what can cost we need biopsy PET scan surgery وفي لسه ongoing study to show the benefit of low dose CT scan for screening of lung cancer. The most important what affect the prognosis is the stage, tumor size من نص سنتيمتر ل1 سنتيمتر بتختلف 2 سنتيمتر also. The tumor biology also we can request for the tumor biology and for there is a new era of a treatment or molecular treatment اللي targeting الALK وال EGFR the biological treatment for which is a new modality for treating lung cancer based on the genetic markers. malignant pleural effusion زي ما حكينا إذا patient عنده lung cancer or bronchogenic cancer and found to have also positive pleural effusion positive for tumor cell, this is stage 4. Usually malignant pleural effusion result تقريبا 43% result from metastatic cancer of the lung, carcinoma of the breast 25%, lymphoma 8% والovarian 4%. So the lung cancer is the most common cause of malignant pleural effusion. Symptoms also, as we mentioned, non-specific, what dyspnea is account for the majority symptoms. Direct metastasis, how it is the pleural effusion can be spread, direct metastasis, lymphatic obstruction, bronchial obstruction with atelectasis, post-obstructive pneumonia, thoracic duct involvement. The characteristic of malignant pleural effusion زي ما حكينا في المحاضرة السابقة تاعت pleural effusion usually exudative. The malignant pleural effusion usually exudative and they have also lymphocyte predominant. مش بتكون أكتر بتوصل 80% لكن lymphocytic predominant يعني من 60 إلى 70% lymphocytic predominant. تلت malignant pleural effusion they have low pH, so 7 less than 7.3. How we can diagnose pleural fluid cytology, biopsy or thoracoscopy, medical thoracoscopy and pleural biopsy or video assisted thoracoscopy by the surgeon, thoracic surgeon and the pleural biopsy. How we can treat systemic therapy, first of all diagnosis and then to find which kind of the bronchogenic cancer. Then we can also go for pleurodesis or putting of Plorax or permanent intrapleural catheter for frequent pleural fluid drainage. This is a malignant mesothelioma, which is a tumor of the pleura. As we see here, lobulated left pleural opacity. Very important to check CT scan, what is very characteristic lobulated pleura for malignant mesothelioma. It is associated with asbestos exposure and can be developed after 35 or 40 years of exposure. It is not associated with smoking. Difficult diagnosed by cytology, thereby this patient need to underwent for pleural biopsy. There are 3 histological type of mesothelioma: epithelial and sarcomatous or mixed. If the patient is diagnosed to have mesothelioma, the very bad and poor prognosis. The patient, if he lives more than 1 year, so please revise your diagnosis. So the patient is having very bad prognosis, and usually they die within less than 1 year. Treatment option: 3 procedures are used اللي هم thoracoscopy with pleurodesis or pleurectomy, decortication, or major surgery extrapleural pneumonectomy EPP. طبعا extrapleural pneumonectomy 5% surgical mortality and a very advanced surgery, or the median survival is 21 months based with epithelial histology, and also we have to refer the patient for multidisciplinary team evaluation. EPP is the most aggressive procedure. It involves the in-block resection of the viscera and the parietal pleura and the lung and the pericardium and the ipsilateral diaphragm. And by this I'm ending my lecture about bronchogenic and lung cancer, and thank you.